everybody. Welcome to another episode of EMplify. I'm your host, Sam Ashu. COVID-19 has placed many of us in scenarios that we are unaccustomed to. Things like being low on resources, whether that's PPE, testing kits, medications, access to consultants, ICU beds, ventilators. These are all things that we have had to become accustomed to not having. And yet, there is an entire population of emergency departments that experienced this long before COVID-19 ever hit. And that's emergency departments in rural America. And so adding a pandemic to rural emergency departments seems like a completely impossible scenario to navigate. So today we're sitting down with two of our colleagues, rural emergency medicine experts, Dr. Harry Wingate and Dr. Ken Gramyk, both of whom are members of the American College of Emergency Physicians Rural Emergency Medicine section, and have taken the time today to share with me and with you their experience in rural America. So gentlemen, would you briefly tell us who you are and where you currently practice?
My name is Dr. Harry Tripp Wingate, and I practice rural emergency medicine for the past 30 years. Joined ACEP in 1999, so I've been a member for 21 years and have enjoyed that. It's been a great opportunity to network with colleagues and really hone my emergency medicine skills. I got involved with the rural section about 12 years ago and served a 2-year term as the chair of the rural section. So that was, again, a great opportunity to meet a lot of like-minded emergency physicians. Currently, I live in Athens, Georgia, and I'm a site medical director, a small ED, part of the Tanner Health System in Wedowee, Alabama. It's just over the Georgia-Alabama line. And we are a single doc shop. Pre-COVID, we were about a 13,000 ED volume, seeing about 30 plus patients a day. And post-COVID, like everybody else, our volume has significantly dropped. Do have a little bit of 8 to 10 hour double coverage with nurse practitioners, but we also have kind of a hybrid model. So we oversee the inpatient service, swing bed, general medicine patients, but we don't have an ICU, so it's more like a critical access type hospital.
I'm Ken Gramyk, and I've been a practicing emergency physician for 30 years. I was residency trained and ABM certified in emergency medicine, worked in some suburban and urban academic centers for about the first third of my career. Been practicing rural EM for more than 20 years now. I moved to Sandpoint here, which is in North Idaho, a little more than 20 years ago, and founded a emergency medicine independent democratic small group. And so we're one of the few small democratic groups that has survived. We have a primary critical access site here at Sandpoint that we serve primarily, and then we supplement staffing it to other regional critical access hospitals. ED size here is basically, we have 8-bed ED plus 3 vertical beds, about a 10,000 annual volume. And it is located in Sandpoint, Idaho, which is a beautiful part of northern Idaho in the Rocky Mountains, about 50 miles from the Canadian border, 75 miles from Spokane, Washington, and has a rural population of about 45,000 people. In the last 2 years, I've been currently the section chair for rural emergency medicine.
Great. Thank you both for taking the time to talk with us today and share your experience. Now, let's start with Dr. Wingate. Tell me what your volume and experience has been like so far with COVID-19 in the Georgia, Alabama area.
There are hot spots. One of the hot spots in the rural areas is Albany, Georgia, which is where I grew up, down in southwest Georgia. And there, it made national news. They had an individual, sort of an index case, a fellow that came down for a funeral, and he was sick at the time that he attended the pre-funeral festivities and infected a lot of people And he had the next day, he had to miss the funeral. He had to be admitted. And no one at that time, it was so early, no one at the time knew exactly what was going on. So there weren't the precautions that we take today. And so a lot of the staff got infected, including the pulmonologists that took care of him. They took care of him for about 4 days, and he was from Atlanta. So he got worse. They ended up transferring him to Atlanta, and that's where he was tested when he returned back to Atlanta and tested positive for COVID. But not until he had infected a large number of people and really set off a large wave of infection down there. And they just now are starting to kind of get their legs underneath them and be able to manage it. But they were overwhelmed down there. But most of rural Georgia has been sort of a similar experience that we're seeing in rural Alabama. And that's, sporadic cases.
And Dr. Gramyk, for you in Idaho, similar?
Idaho has only had 2,300 cases so far, with about 72 deaths. Our county has only identified 4 cases, and we've had no deaths. But our county is it's sort of more of a resort town destination. We have a ski hill that's 11 miles away from us, and then we have a large Lake Pend Oreille, which we have a lot of tourists and summer visitors there, cottage people, snowbirds that come back to the area. And so we were very concerned that we might be hit hard by community spread of this disease, like had occurred in other areas in Idaho.
Okay, now, Dr. Wingate, in your area, you are covering both the emergency department and the intensive care unit. What does that look like during a COVID-19 pandemic? Are you admitting all those patients? Are you having to transfer many? What's your practice been like?
Yeah, so that's a good question, because these small facilities, the size that I work in, they don't really have, even if they had ICUs and had some ICU beds, they really don't have the staff and specialists to really manage a ventilated COVID patient. As you know, if they have to go on a ventilator, they're pretty sick, and they require all kinds of special procedures and draping and filters and proning and a whole bunch of techniques and tactics that you're just not going to find regularly practiced. So what we have done, this is part of the insightful leadership at Tanner, is that they have designated our facility, since we're the smallest of the 4 facilities, as the COVID-free facility. So we don't admit suspected COVID patients or persons under investigation. If someone is sick enough to require supplemental oxygen and we suspect it's a COVID patient, we will transfer them to our mothership hospital, and they have a dedicated COVID wing that they will admit them to. And if they need to go, to the ICU, they've got a COVID prepared area to handle all the COVID patients.
And being at a non-COVID center where you're having to transfer patients out, are you required to test somebody before they can go, or is this purely based on clinical suspicion?
It is based on clinical suspicion because, testing, the testing for the antigen, PCR, their fastest turnaround time is 4 days. But if they're not sick enough, they don't require oxygen, and they're not sick enough to be admitted, if they didn't have any other comorbidities and it was just sort of an uncomplicated flu type picture, we would tell them that, there's a possibility they could have COVID. They need to isolate themselves, for the next 14 days, assume that they have it. And if they get worse, come on back, because there wasn't really at that time, there's not really any specific therapies that we could begin if we knew for sure it was COVID. We just make sure it's not other conditions, because other things like COPD and CHF and heart attacks and all those emergency medical conditions don't go away just because we're in the middle of a viral epidemic.
Dr. Gramyk, in Idaho, you have also seen some changes and had to restructure some things for your rural practice. Tell us how COVID-19 has impacted you.
So probably the first week of March, we basically ramped up all of our changes that really affected both our use of PPE and precautions in the emergency department, as well as our ED operations and flow. So I think one of the advantages of being a small organization is your ability to respond a little bit more quickly also to these kinds of crises. We reduced our shift hours to shorter shifts and canceled our vacations and travel. No one was going anywhere, so we ended up doing more shifts and shorter shifts, and had the ability to do that. But we had to really redesign our whole ED operations and flow. We had to control hospital access, screening, all people coming in emergency into the hospital, change visitor policy to allow no visitors, and surgical masks for all patients that were being treated, and basically closed our waiting room too, which I think a lot of emergency departments have done.
Now, tell me, Dr. Gramyk, has your experience been similar to Dr. Wingate's? I mean, you're up in Idaho, but you're also in touch with people through the ACEP rural EM section. And are you practicing in the same manner? Do you have the same constraints on ICU beds? And are you having to transfer patients as well?
So practicing in a resource-limited environment, this is something that affects all rural hospitals. So typically, you're going to have a very limited, either very limited or sometimes no ICU capacity. Many critical access hospitals may have 0 ICU beds. Some have maybe up to 4 ICU beds. So when it came to a pandemic like this, where patients could be critically ill, requiring intubation and ventilatory care, most hospitals would be transferring all of their critical care patients. Anyone that was intubated would likely be transferred to a regional center. So there's likely not to be any intensivists available at a rural hospital. So even if you had, patients that could be intubated or on ventilators, limited resources for who's going to be managing those intubated patients. So that, of course, impacts the other impact is then transferring those patients out to regional ICU bed, and the capacity of your regional system, if it's experiencing a surge, if you're transferring them out, obviously affects the ability for them to get a bed and accept those transfers.
And where you're practicing, has there been any discussion about trading patients? As you send a COVID patient, if the transfer center is full, maybe they can send you someone else back to your community in exchange?
We actually were involved in some discussions regarding that. It's fortunately never gotten to that point, but what we were thinking about doing was if we had to transfer a significant number of patients to the regional center, that maybe perhaps then we could take back patients that were maybe non-COVID and lower acuity.
Now, it seems as though the majority of emergency departments in the U.S. actually experienced a significant volume decrease during this pandemic, unless they were in one of the urban centers where there was a large outbreak. Has that been your experience collectively, both of you?
Correct. Yeah. And patients tell us, we're just afraid to come to the emergency room. And so much so that I think that's the biggest part of the volume reductions. A lot of the, what we always complained about is, urgent care or primary care type cases. People are, in some serious cases, people are self-selecting to stay home, when that's where, from a business standpoint, that's where our margins are. And so it's hurt our company. And, we're financially trying to deal with this like everybody else. I know these small hospitals are hurting as well. we've had since 2010, we've had 130 something rural facilities close. And in 2020, pre-COVID, there were already 8 that were scheduled for closure. So when you take out someone's outpatient services, you reduce their ED volume by 50%, you're just going to stress them to the point where if they don't have a large mothership like we do, or they don't have a county government that's willing to subsidize them financially, they don't have any option but to, file for Chapter 11 or be bought by somebody. So we're yet to see how this is going to play out, but I would imagine it's going to further reduce the number of rural facilities that we have. They mentioned the number 2,000. That's probably fairly accurate. I think there are a little less than 5,000 acute care facilities in the country, and almost 35-40% of them be classified as rural facilities. So it's a big group, and often forgotten and overlooked part of the system, but it's out there.
Yeah, well, I think it's been a huge change. I think particularly during the whole nationwide lockdown period, we experienced the same kind of sort of voluntary reduction in the volume of ED visits, and probably 20 to 30%. And we also, saw what other people were seeing with this decreased visits for STEMIs and strokes and times trauma and so forth, as people were either avoiding the hospital or in some cases maybe trauma. The MVCs weren't happening because people weren't driving as much, perhaps, but about 42% of the hospitals in America are actually rural or small hospitals, and they account for about 17% of all nationwide emergency visits. With all these hospitals basically canceling their elective procedures and surgery based and shutting down a lot of their services that were previously available, I think it's going to have a huge economic impact on the sustainability of those hospitals.
And Dr. Gramyk, what have you seen in the way of response to these drastic volume decreases in rural hospitals?
Yeah, so I think immediately when we went into this new mode of the pandemic, the hospital, coinciding with the reduction in elective services, they basically furloughed a lot of nursing and providers and healthcare workers, and then now it's kind of transitioned into some layoffs or firings or terminations as well. So I think that this is probably not unusual for other rural hospitals. And the question, I think, will be as they kind of reopen up, if what services are they that they once had, are they going to reestablish versus decide that they just can't provide those kinds of services.
And that's a critical point, because in the rural communities, you're providing health care to people who are quite far away from a urban center. Dr. Wingate, in your Georgia, Alabama area, how far is the next hospital?
Yeah, we're right in the epicenter of 4 major communities, all about 45 minutes to an hour away. So we really are in the northeastern part of Alabama, in sort of an isolated area. It's beautiful country, lots of rolling hills, kind of at the beginnings of the foot of the Appalachian mountain range that starts in northeast Alabama and runs up through the northern part of Georgia on up into Tennessee and North Carolina. So it's beautiful country, but it's still very, very rural, very agricultural there, and not a whole lot of healthcare resources for the folks.
Now, that's an hour's drive for the patient, but what if you're having to transfer someone? Now you need a EMS unit or an ambulance to take them. What's the county ambulance staffing like?
Yeah, it's like a lot of these rural counties. You usually have one service that covers the county, and we actually have two services. They divide the county up into almost halves, but they do have a limited number of units on. So a lot of times transfers do get delayed because of logistics. They just don't want to leave the county uncovered for 911 calls. Sometimes we have to, if we can fly, we'll utilize the helicopter services to help keep the county covered. But it can be a challenge, and that's a part of one of the challenges of being a rural EM doc pre-COVID and during COVID. Fortunately, with the COVID patients, we do have an agreement with our hospital within our hospital system, so we don't have to fight, to get people transferred. If they need oxygen and we suspect they're COVID, they're gonna take the patient.
And for you, Dr. Gramyk, how remote is your location?
Certainly there are places that are much more what I would call frontier emergency medicine. I mean, other where they really they're really isolated. I mean, we actually probably an hour by ground, basically, we could get someone to a regional level hospital, and some additional services maybe an hour and a half away. So we're kind of right on the edge there in terms of our location and getting people in a time sensitive fashion to higher levels of care.
Okay, one more question for the both of you. Looking at telemedicine, there's been a big increase in that in the entire nation with the COVID-19 pandemic. Is that something that both of you are utilizing now in a more robust manner than you did previously?
Yeah, we've been using iPads. That's one of the aspects of medicine technology that's being accelerated right now because CMS, has waived a lot of the regulatory issues surrounding telemedicine. So, and a lot of facilities are seeing that it's helping not only keep the staff and patients safe, but it's decreasing the amount of PPE that's necessary. Having to change PPE in between visits with patients and things. You can now do telerounds and things like that.
So yeah, I think that telehealth has huge potential, and it's always been a huge potential. It's been used in some rural places are having more robust systems pre-existing than others, but we certainly have kind of done our own sort of local telehealth type of implementation. It's really helped us in the emergency department with the ability to, and that really helps us on conserving PPE. So we would use either two-way radio communications or basically like an iPad with two iPads with FaceTime. So we could communicate with nurses that were in PPE, that were outside screening and maybe testing, swabbing suspected patients for COVID. We could also do that inside with the nurse inside an isolation room if they were caring for someone who was a person under investigation and we were suspicious that they may have COVID disease. So that way we wouldn't have to use quite as much PPE in terms of, going in and out of rooms and so forth. So it's really helped us on that level. And then I'm sure that, there's been obviously a huge increase in its use, even with the local clinics and doctors' offices, so that they can communicate with their patients without them being in the office or in a waiting room.
Well, thank you both for taking the time to talk with us about some of those challenges that you experience in rural emergency medicine. We have all experienced some of these, like the problems with acquiring enough personal protective equipment, but some of the things we don't think about are transport times and access to EMS to move patients, and how the financial impact of COVID-19 is affecting the overall health of a hospital, especially a critical access hospital that is already financially constrained and has extremely limited resources. So thank you to you both for the work that you continue to do in rural America. And thanks again for joining us on the podcast. And thank you for listening. As always, if you have comments or want to reach out to us, dial the phone number and leave us a voicemail, or use the email included in the show notes. I look forward to hearing from you. Until next time, I'm Sam Ashu.